SA node and the AV node do not go ahead and fire like they should. The ventricles will pick up, but that has an intrinsic rate between 20 and 40 beats per minute. One other thing to note, that if you do have no P wave and the AV node doesn't go ahead and take over, the ventricles, it's going to be a wide complex too, a lot of times for these patients. So the other things we have to remember, that these bundle branches, if the various coronary arteries do go ahead and feed the bundle branches, so if we do have a block of some type, it's usually due to, or it may be due to, lack of oxygen getting to areas of the bundle branches. So we're going to start by taking a look at the different types of blocks. We'll start with the first degree heart block. We see so many patients that do have a first degree heart block, and generally nothing is done for these patients. We don't have to go ahead and do any treatments for them. They're usually asymptomatic. When we take a look at any of the blocks, the big thing to actually look at is our PR interval, and that will help us identify which type of block it is. So in a first degree heart block, the PR interval for a normal patient should be anywhere between 0.12 and 0.20 seconds. Bless you. When we have a PR interval that's greater than 0.2 seconds, that's when we go ahead and we state we have the first degree heart block. All of our PR intervals have got to be consistent though. There's no varying of the PR intervals. Now, what's happening here in the heart is that the SA node goes ahead and fires. The AV node then hangs on to that impulse a little bit longer before it sends it down the bundle branches to contract the ventricles. What can cause or further problems that we might be looking at with this is that as the blood flows from the atria to the ventricle, it's basically overstretching the ventricles. It's allowing not too much blood to get into the ventricles. And it's just like when you look at a rubber band, if you're constantly overstretching it, it kind of gets loose and it gets flimsy and it doesn't contract as well as what it should. So over time, we can see a dilated heart failure start to occur with these patients because of the prolonged PR interval, or the amount of time that that AV node is hanging on to the impulse before it goes ahead and lets it go through. With a second degree type 1, this one also, I mean, we can see people, it's not so much of a big deal as it is with higher degree blocks, but again, we take a look at the PR interval. We have a normal PR interval on our very first complex. It gets a little bit longer here, longer until it drops a beat. And then it goes back to a normal PR interval. And again, same thing. The impulse is being sent from the SA node to the AV node. First time it lets it go through. Second time, it's like it hangs up there a little bit longer until it ultimately will block the impulse from making its way down the bundle branches to the ventricles. Now, this can be concerning because of the fact that anytime we delay the impulse or the contraction of the ventricles, we see a decrease in our cardiac output. Still, with these patients here, it's concerning, but we don't usually see a rate less than 60 beats per minute with this type of heart block. Where we start hitting the higher degree blocks, the second degree type 2, again we look at the PR interval. For the most part, the PR interval is going to stay consistent, 1 P wave before every QRS complex. But we do have times where it completely blocks the impulse. You know, you're going along normal, we have a P wave, and then that impulse gets blocked. And then it picks up and it starts on its own until it blocks the impulse again. This is also concerning because of the fact, for whatever reason, the ventricles are not able to depolarize or contract, and again, we can start losing cardiac output. Sometimes with this, it's not usually nice like this. There's other ones out there that show it a little bit more consistent. It can be just a fluke where it happens once, which again, we're not worried about. But if it's a consistent, we take a look at how many P waves for every QRS. Now here we have a 2-to-1 conduction. We get more concerned if it slows down and we end up with like a 3 or a 4-to-1 conduction with these patients. And then we come to our third degree heart block. Again, we're looking at our PR interval. And our PR interval is all over the place with it, and there's no correlation to how it is associating with the QRS complex, and that's the ventricles contracting. If you actually take and you march it out, your P waves all march out, your QRSs, they all march out. It looks like a nice regular rhythm, but the atria and the ventricles are not working together, which means that sometimes you're going to have overfilling of the ventricles, sometimes you're not going to have, or very little filling of the ventricles. So again, we can have either too much blood being forced through or dilating those ventricles, or not enough blood making it to the ventricles to be pushed out through the rest of the body, which again is going to decrease cardiac output. We also know this as a complete heart block when we take a look at it. Now, when do we consider bradycardia to be an emergency? We have patients all the time that will have heart rates in the 50s, and it's because they're athletes or they're really in good shape. Or we might have someone who is really asymptomatic. According to our protocols in Region 10, we are not treating anybody who is asymptomatic. It's going to be straight, just monitor them and watch. American Heart Association has a little bit different of an avenue. They think that, well, speed it up a little bit, we'll give them some atropine. Now, there's a slide coming up here. Let's just go to it right now. Atropine is a medication that mainly speeds up the conduction process through that AV node. If we have a slow heart rate, it's to speed it up so that the ventricles don't overfill, don't become dilated, and then it'll force blood to the rest of the body. Atropine does other things too. It is an anticholinergic, which will go ahead and work on those patients who have like organophosphates or other nerve agent type, weapons of mass destruction. It's part of our Mark II kit or Mark I kit, or what is it, Duodope now that we're using. The dose that we give for someone who has a heart rate is 0.5 milligrams. But remember, if you push too much of it, you can actually cause paroxysmal bradycardia, which you can make it worse. Some of the things to think about when we're giving atropine. Atropine will dry everything out. It will dilate the pupils. It will cause flushing of the skin. People don't generally care for it all that much. They might end up with a headache and some blurred vision for them. So we don't want to give it to anybody who's tachycardic because that impulse is going through the AV node just fine. But when we take a look at regular bradycardia, meaning no blocks associated, atropine should work fine to go ahead and raise the heart rate if the patient is unstable. Stable, again, consists of mental status is good, blood pressure is above 90, systolic, skin's pink, warm, and dry. But if they become unstable, they have altered mental status, blood pressure is less than 90, they have chest pain, they're lightheaded, they're weak, they're dizzy, skin is pale, cool, and diaphoretic. That's when we can go ahead and try atropine. Now, when does atropine work in a patient? Well, if it's a normal rate, but bradycardic, it should be fine. When we have someone who is having some type of heart degree block, it's not going to work as well. Atropine doesn't work in a second degree type 2 or a third degree heart block because third degree heart block, it's pushing through the AV node just fine. It's not really blocking it like it should. It's just that the ventricles and the atria are not functioning together. Second degree type 2, the PR interval is consistent. It's making its way through okay, but for whatever reason, it's blocking every so often. If the impulse is being blocked, atropine is not going to help them. And so, even though we go ahead and we give it, and I do know American Heart does recommend that while we're getting the pacer set up, we can try atropine, but the likelihood of atropine really working is minimal. So if you had to choose, if you were by yourself, in the back of the ambulance, and you had to choose between giving a patient atropine or starting the pacer, we should always go with starting the pacemaker. Our protocols right now still say Valium. We did send out an email, I think Adam did last year, and stated that we don't have Valium anymore. We have Versed, and that's what we're currently using. And we're using it because the pacemaker is kind of uncomfortable for our patients. So, again, we don't delay medications or pacing for any medications. Once we go ahead and we get the pacemaker going, if it's that unstable, then yeah, go ahead and give the Versed first. Don't forget, because it is painful, we could try some fentanyl, 1 mic per kilo, up to 200 mics total. And we manage the pain appropriately here. If that pacemaker doesn't pick up, if it's not working like it should, then we can go ahead and try another dose of atropine. Just remember, too much atropine can cause that paroxysmal bradycardia. If blood pressure is still less than 90 systolic, we have to look. What is causing the bradycardia? Try and figure that out. What is causing the low BP? Is the bradycardic rhythm that's so slow causing a decrease in cardiac output, which is causing our blood pressure to be low? By speeding it up, in theory, it should increase blood pressure. But it could be other things, meaning cardiogenic shock, where the blood pressure is low, or shock, which is down the downward slide, that speeding up the rhythm is not going to increase blood pressure. So we need some type of vasopressor to increase contractility, make the heart beat a little bit harder in order to raise that pressure up. If that's the case, we start with dopamine, 5 mics per kilo, and we're gonna go ahead and titrate up to, sorry, I'm just gonna shut this off here. We're gonna go ahead and titrate up to 20 mics per kilo. Dopamine is very easy to set up. If you remember to figure out what your rate is, take your patient's weight in pounds. So if they're 180 pounds, we drop that last number, you're left with 18. Subtract 2, you're gonna set it up at 16 drops per minute to go ahead and have that 5 mics per kilo for your dosing. Very simple, just bleed it through and hook it right into your regular IV. Shut your other IV off, and you should be all set to go for these patients. Now, when we talk about pacing a patient, it's, we have to go ahead, first of all, and set our rate at 80. When you pace a patient, what you're looking for is that pacer spike right before the QRS complex. Remember, your QRS complex will be a little bit wider. And once you have that pacer spike right before the QRS complex, what we have is called electrical capture. The next thing you have to note is feel a pulse. Do I also have a heart rate of 80? Then I know I have mechanical capture. As we're going through, after we set the rate at 80, we turn up the milliamps, slow enough that we can kind of watch to see when we go ahead and get that capture. Once we do, we're going to go ahead and document the settings so that once we move into the ED, they can go ahead and set their pacemaker up right approximately at the same levels. Again, that YQRS complex is going to follow that pacer spike. So, anybody have any questions on standard bradycardia or pacing? All right. So we move on to the tachycardic rhythms. Again, why is a patient tachycardic? I think it's really important to note that any type of rhythm that you have with your patient, we have to ask ourselves, why are they? Try and figure out so that we can appropriately know how to treat them. They could be tachycardic for various reasons. I always laugh when I do the National Registry examination in the static cardiology, they have a rhythm on there that's a rate of 150, right on that borderline. And all of the students that come in, they think that it's got to be cardiac in nature, so they're cardioverting and they're giving lots of fluids. But in this one, the patient states it's a 21-year-old patient who was out at football practice on a 90-degree day. It's been going for 4 hours, very little to eat or drink. And it was something as simple as bring them out of the heat, cool them down, give them fluids, and that would lower the heart rate for the patient. Decreasing body temperatures, increasing fluids. We have to go back to figure out why. That story of what's going on is going to be so vital on how we treat our patients. When we talk about the tachycardias, we also have to ask, are they stable or unstable? That's probably the most important question to ask because that'll help us identify which pathway we're going to go down. I'll come back to adenosine here in a minute, but we have two different types of tachycardias. We have what we call narrow complex tachycardia and wide complex tachycardia. When we start with a narrow complex tachycardia, we think of supraventricular tachycardias. Now, SVT is a garbage term. It puts a whole bunch of different fast rates into one category because we can't really identify what is going on with the patient or what the rhythm is until we slow it down. It could be an AV nodal reentry, it could be a multifocal atrial tach, it could be AFib with RVR, a rapid ventricular response. So until we get that rhythm slowed down, we don't really know what we're dealing with, and then we can appropriately treat it. So we actually say that 150 beats per minute is our standard for someone who is in a fast rhythm. We call it, that SVT in the meantime. So when we take a look at our supraventricular and our stable patients, meaning again, they're alert, blood pressure is above 90 systolic, they're pink, warm, and dry, and we consider them stable, we'll start off with what we call vagal maneuvers. Up to you how you ask. I usually will pull out a 10 cc syringe, pull the plunger out a couple times, leave it halfway, and then I ask the patient to blow on it. It's better than trying to explain to them how to bear down. It's easy for kids too to understand, try and blow up the balloon kind of thing. It makes things a lot easier for a lot of people when you're trying to get them to do vagal maneuvers. So the first drug we're going to go ahead and use is adenosine. Now, if I go back to adenosine slows the conduction down through that AV node. That's its purpose. So adenosine speeds it up, atropine speeds it up, and adenosine slows it down. We actually will only give 2 doses of adenosine. We start off with the 6 milligrams, we do a rapid IV push, and then the second dose is 12 milligrams. American Heart goes ahead and says you could try one more 12 if you wanted to. The big thing is that we get that in fast because it's only got the half-life of about 8 seconds. So we started in the AC, and we go ahead and we push it in fast, and then we follow it up by a 20 cc flush. If you've ever tried to give adenosine and switching around different syringes to do that flush, little trick of the trade that works pretty well is that start by pinching off your normal saline. Well, take your bag of normal saline and turn it up wide open. Pinch it off, push your adenosine, and then go ahead and open it up and squeeze the bag. That's going to be a lot faster to get that medication in there a lot quicker than unscrewing the one syringe of adenosine and screwing up a 20 cc syringe and then pushing it. You're getting that medication to go in a lot faster. So either way works, just different things to kind of follow and do. Some of the things though that we want to be worried about, we don't want to give adenosine to someone who's in a heart block because again, we don't want to slow down the conduction. We've already got a slow conduction. Sick sinus syndrome, again, we're probably not going to know that. Make sure you identify with your patients what's going to happen because it gives them that very weird feeling. Some people have said it feels like they're falling. You're also going to know that I push the print button. You're going to watch them go into that almost asystolic rate, and then hopefully it will go ahead and pick up again. And it's kind of sometimes a little nerve-wracking when we watch it. So when we go back to here, we give the adenosine 6. If it doesn't work, we go on to 12. Give it a little bit. I think it says here after 2 minutes, go ahead and try the 12. Now, if it is not working, then we know it's not that supraventricular. We know it's probably atrial in nature, which is why we go ahead and we switch to verapamil. And we go to 5 milligrams IV push. You want to make sure that you're pushing verapamil very slow, over 2 minutes. If we push verapamil too fast, it can cause extreme hypotension in our patients, and we don't carry calcium chloride to reverse the effects of verapamil. And the last thing we want to do is take this patient who is probably not doing the best anyway and make them more hypotensive. If our patient is unstable, altered mental status, blood pressure less than 90 systolic, this is where we're going to cardiovert them. Remember, when you cardiovert, it is different than defibrillation because you're going to put that sync button on, and it's going to go ahead and, I was just looking to see if my little drawing was still up here, but it wasn't. You're going to go ahead and it's going to flag on the top of the airway. And that's where that electrical impulse needs to happen, when the heart is depolarizing. If you if you shock them when it's in the repolarization stage or during that T wave, you risk what we call RNT phenomenon and sending your patient into ventricular fibrillation. So we want to make sure that we're hitting that sync button. Every single monitor is a little bit different, so you have to know what your manufacturer states as far as your cardioversion joules. We give you the cardioversion joules in monophasic, even though we don't make monophasic monitors anymore. This here that's in our protocol really needs to be updated, just because half of these monitors that people are not even using anymore. But 100 joules, 200, 300, 360 joules biphasic equivalent is what we're going to cardiovert someone at. Again, using Versed, give them a little twilight, it's not going to be comfortable. Might want to even consider a little bit of fentanyl, 1 mic per kilo, to go ahead and alleviate any pain if your patient is still pretty conscious and with it at the time. Look to figure out why are they going so fast. And again, the story behind it is going to be important to help you identify. It could be something as simple as cooling them down. If they're febrile, it could be something as simple as giving them fluids. They could be shocky. You don't want to go ahead and have someone who's hemorrhagic shock and give them adenosine. Not going to be a good situation for them. So why is my patient tracking along? If it is still staying with the narrow complex tachycardia, we can have what we call AFib, or multifocal atrial tach. Patients who have AFib live that way all the time. We don't really get concerned about AFib unless a patient has uncontrolled AFib. And then we're looking at a rate of about 120 or greater with signs and symptoms, or they're being symptomatic. Lightheaded, weakness, dizziness, altered mental status, blood pressure less than 90 systolic. Doesn't have to be all of them, just has to be some of them. Okay, and we want to make sure that we're slowing that rate down a little bit. The other thing, remember with AFib, what's going on in the heart? The atria is sitting there fibrillating. And so by us going ahead and kicking them out of AFib can possibly dislodge a clot that might be hanging around in those atria, which could lead to a stroke or even a heart attack, depending on which direction it actually goes. So when we take a look at our rapid atrial fibrillation, or A-flutter, narrow complex tachycardia, if someone is tacking along greater than 150 beats per minute, it's going to be really hard to identify. Is this regular or is this not? Which is why we start with the adenosine. If greater than 150, if that doesn't work, we move on to the verapamil. Verapamil is a calcium channel blocker, works in the atria, and it's going to slow the rhythm down or decrease, kind of relax the atria from going so out of control. So if we know that they're sitting at about 120, they're not tolerating it well, they're stable, we can try Valsalva maneuvers. More than likely those are not going to work. And then if necessary, verapamil. I'm going to be honest with you, most doctors, if you call into medical control, are not going to want you to give the verapamil. Verapamil is a very nasty drug. Again, we don't have calcium chloride. Most will say, you know what, just if they're doing okay, hang on until we get to the ED, where they can give them Cardizem, or a drug that's going to be a lot nicer on their bodies. But if it's not, 5 milligrams IV push, again, make sure it's slow, over 2 minutes, and then you guys will probably be at the hospital before the second dose. Now, the unstable. This makes me extremely nervous, and I don't call medical control for a lot of direction out there. I probably should more, but there's been a lot of new studies about new onset AFib and continuous AFib, out of control AFib, and actually cardioverting these patients. Because of the fact that if we cardioverted and they do have a clot, do we cause a stroke? Do we cause a heart attack getting lodged into one of the coronary arteries? So to be very honest with you, if you have a patient who's unstable, you believe it to be atrial fib or AFib with RVR, call medical control. control and ask them, do you want me to cardiovert? I would feel better if you did it, and more than likely the doctors are gonna say, yeah, hold off on the cardioversion until we can try something else. But if you do go down that pathway, cardiovert, 100, 200, 300, 360, don't forget about giving them some Versed, 2 milligrams up to a max of 10, and then giving them something for the pain, which is the fentanyl, 1 mic per kilo. But I anticipate seeing a change in this with our new protocols as we go through them here. So as I said, verapamil relaxes the coronary smooth muscles within our patients. It decreases SA and AV node conduction, so it's slowing down those atria and slowing down the impulses getting to the ventricle. It will also cause a increase or dilates our peripheral arteries, which can cause a patient to become hypotensive. So we have to be very careful. Do not give it to a patient who's bradycardic, in a 2nd or 3rd degree type AV block, heart failure. Those are some big ones. It is going to cause some dizziness, and again, if you push it too fast, bradycardia and hypotension is going to be your big problem that you're going to anticipate with this drug. Now we come to our Y-complex tachycardias. I don't know how many of you guys actually realized in our last protocol book here that we had a very big error in it, and that was with our polymorphic Y-complex tachycardia. Polymorphic Y-complex tachycardia is otherwise known as Torsades. And if you actually, I'm going to just go right to here, stable polymorphic Y-complex tachycardia, you're not going to have that happen. The other thing is they talk about if it's polymorphic Y-complex tachycardia and they're unstable, they say to go ahead and cardiovert. You can't cardiovert polymorphic because you're not able to find that R wave consistently. You have to actually defibrillate polymorphic Y-complex tachycardia. I don't know how we got that through on our last one. We didn't pay attention very good on that, so I do anticipate us correcting that. But when we start with our Y-complex tachycardia, those that are stable, they have a pulse. They may not have a pulse for long, they may not stay stable for long because the heart can only beat that fast for a certain amount of time. We start off with adenosine. Now, for the most part, adenosine will not work if it is truly ventricular in nature. The reason we give it is that American Heart came through some studies and they said, hey, monomorphic Y-complex tachycardia can look very similar to SVT with aberrant conduction, meaning that it's tacking along really fast, but there's something that's beating which is making it look wide. And so if it is, adenosine might help. What we're looking though to do is to use our amiodarone. And we put 150 mLs in, or 150 milligrams in 100 cc's of D5W, running in over 10 minutes. Now we've always taught you anytime you piggyback any drug, we go ahead and use microtubing for it. With this, because we're only running in over 10 minutes, you want to use macrotubing. It would be 660 drops per minute that you would need with microtubing versus 1 drop a second if you're going to use macrotubing at 10 drops per ml. So you want to make sure that you're using the one, and again, not running it in too fast, leave it a little bit slower, about 1 drop per second. Again, stable polymorphic Y-complex tachycardia, it's not going to happen. These people, if they're polymorphic, are going to be in torsades. And if they're in torsades, they're not going to have a heart rate, so you're going to be defibrillating them. If we have a Y-complex tachycardia monomorphic and they're unstable, these patients here we want to cardiovert. Remember, stable medicate, unstable electrocate is the easiest way to kind of remember what you should do for them. Our cardioversion again is very simple. It's 100, 200, 300, 360 joules. And the big thing to note with this is that if they start off unstable, we can cardiovert right away using our Versed. Again, don't delay cardioversion for sedation. But after we do that 100 joules, if they don't convert, here's where we're gonna give our adenosine, or amiodarone, 150 milligrams in 100 cc's of D5W over 10 minutes. Now, if you started off with a patient who was stable, they were doing really well, you got the amio drip going, and then your patient became unstable on you, you CardioVert here, we're not gonna do a second drip, just, use the first one, and then 100, 200, 300, 360 joules. Again, don't forget about fentanyl for pain management, don't forget about Versed for these patients. So amiodarone works to it's an antiarrhythmic, it goes to settle down the ventricles of the heart. It also does work in the atria, but we mainly use it for ventricular areas. The only problem that you're going to see associated with someone who is using amiodarone, if your patient converts and you're watching them, they go from VTAC to regular rhythm, one thing to watch is the QT interval. With amiodarone, these patients can end up having a prolonged QT interval. And the longer that QT interval gets, the closer it gets to the P wave and having that RNT phenomenon. And that's the last thing we want. If you notice the QT interval is getting a little bit longer with these patients, stop the amiodarone drip. Other things to watch out with amiodarone is that it can cause hypotension. And because it's an antiarrhythmic, it could decrease the cardiac output by decreasing the contractility of the heart, meaning that heart's not going to be beating as hard as what it originally was. Megsulfate is a drug that we use for someone who is using or has polymorphic wide complex tachycardia. That's our Torsades. We use megsulfate for various things, but it's a smooth muscle relaxer. It inhibits smooth muscle contraction. So, someone who is in labor, preeclampsia, seizing, it will help the smooth muscle of the uterus from contracting. It will also help those that are having asthma attacks. Currently, we use it only for pediatrics, but it does work for adults for bronchoconstriction, bronchospasms, to go ahead and cause breathing to be a little bit easier. The doses are a little bit different. So with Torsades, we're using 2 grams in 100 mLs of D5W, and we're going to run that over 5 minutes, and that's for your monomorphic or polymorphic tachycardia, Torsades. It also can be used for OB, which we're using 4 grams in 100 mLs, and we run it in over 15 minutes. And then our patients who are pediatrics, I think it's 25 milligrams per kilo in 100 cc's of D5W, and we run it in over 15 minutes, I believe it is, for that also. When we have patients who go into cardiac arrest, we have 2 main pathways now. We have one that has a rhythm, VFib or VTAC, or we have the PEA and asystole. PEA, asystole, very easy. The only thing we're going to go ahead and do here is CPR, manage the airway, and give epi every 4 to 6 or 3 to 5 minutes. What's nice though, if you go ahead and always give your drugs, either one of them, at the start, as soon as you shock or do a rhythm check, and you go right back to CPR, go ahead and give your medication right away. Because then you know for the next 2 minutes, you pause and then you start again. And it helps you keep your time frames a little bit easier. So every other pulse check or every other rhythm check with asystole, you would be giving epi for these patients. When you talk about your VFib, the first pulse check, you go back to CPR, you give epi, you go do 2 minutes, the next pulse check and start CPR, then you can go into your amiodarone. Amiodarone here, we're given 300 milligrams IV push. Okay, and then every other one you could rotate between the 2. Epi, then amiodarone, then epi, then 150 milligrams of amiodarone. And then after that, it's just epi every 2 times. Don't forget that you got to switch your compressors every 2 minutes to keep good, solid compressions at a good recoil, a good rate, good chest recoil. Don't forget to use your capnography, because your capnography is going to be very helpful in identifying, is my patient still able to have cellular metabolism? Meaning, do we transport them? Are they gonna survive, or do they have that capnography of less than 10 millimeters of mercury? And those patients we ask to withdraw resuscitative efforts. So, if we get a pulse back, we're gonna go ahead and transport. We're still working them for 20 minutes as we find them. Despite that they're VFib, VTAC, asystole, PEA, whatever it is. Call in medical control, let them know what you have, let them make the decision whether they're gonna go ahead and withdraw efforts or not. So, and that's it. Yeah, like I said, very, very short one this month.